Hi, everyone. Thank you for coming out. We're going to have Tufts, BU, and Harvard on the line, so that's awesome. I'm Jessica with the Senior Specialist with the University Relations team at Pacific Dental Services, and on the call with us today, we have Kim Brozovich, who is also on the University Relations team. She's a director. We have Geraldine Riley, the regional manager of the Massachusetts region, and Yuritsi Thomas, the regional marketing specialist. We're going to be learning the step-by-step single tooth implant restorative techniques from Dr. King today. Dr. David King graduated from the University of Missouri, Kansas City, and he is a PDF-supported dentist practicing in Missouri. So thank you. Just a few minutes of housekeeping. We do want to make sure everyone stays muted. We do have a chat feature, so please feel free to put all of your questions in the chat. We want to keep it as interactive as possible. And then also make sure in the top right-hand corner of your screen, you'll see 3 little dots. You want to just make sure that your name is changed to your first and last name as you'd like it to see on this continuing education certificate, as well as how you'd like it entered in for the raffle. So without further ado, thank you, Dr. King. I'll let you take it away.
You bet. Thank you for having me. So I've done a few of these webinars before, and hopefully you'll get some value out of what we're doing today. Really, the purpose is to share some information with you, some things that I've learned, and hopefully give you some helpful tips to go forward. So like Jessica said, I'm a Pacific Dental Services supported owner doctor. I've been working with Pacific Dental Services for almost 7 years. So let's talk a little bit about my journey. So this is me. So I was actually born out west in Utah. I grew up in Idaho and Montana. And then I lived in Kansas City for about 20 years. Studied jazz trumpet at Central Missouri State University before taking a 2-year missionary trip to Taiwan. I learned to speak a little bit of Mandarin Chinese there, and when I came back, I changed my major to business, following which I married the daughter of an orthodontist. And everything went downhill from there. Just kidding. So after orthodontics, after marrying the daughter of an orthodontist, I changed my major to dentistry and began focusing on dentistry at the UMKC School of Dentistry. 2006, I graduated, managed to procure that diploma, and I started a scratch practice outside of Kansas City in Liberty. Fortunately for me, I was able to be fairly successful for a little bit early on, and working through that challenge, was able to buy another practice and start my own group. Some things happened with that group. Eventually I sold my 2 offices to another group, and things didn't work out with the larger group I sold to, which was not Pacific Dental Services. And I decided to look for another job opportunity, which brought me to partnering with Pacific Dental Services in Albuquerque. After that, the rest is history, as they say. We relocated back to Missouri to be closer to family. And currently I work at a main office in O'Fallon, Missouri. Beautiful O'Fallon, you can see behind me. It's kind of dark here. I also have small shares in an office about 15 miles down the road in St. Peters, Missouri. So as we all should do, let's talk a little bit about what your why is. So for me, this is my why. This is my family. You know, I have 5 kids. My oldest is in college. I have one that just turned 18 a couple of days ago. A daughter here that we're trying to teach how to drive. A son that just got braces about a week ago. And believe me, apparently it's a lot harder now than it was when I had braces. And then my youngest is 9. So the question is, what is your why? And I would encourage you not to aim too high. Don't miss your why. Oftentimes we focus on the things like, you know, the pie in the sky, the castle there. That's a Disney World trip, of course, from a few years ago. That's not where your why should be. Your why should be the people in your life, hopefully. So why I do what I do, it's all about the people. It's all about my family and about the patients that we serve. So let's dig a little bit into our objectives. We have 3 main objectives. Primary objective is to provide methods and processes to diagnose and educate patients on single-tooth dental implant therapy. I want to assist in understanding the options available to you as the restoring dentist when restoring a single-tooth dental implant, and then articulate some of the workflows for successful single-tooth dental implant restorations. So I've got most of these images, almost all of them, just a couple don't come from my own individual cases. This casework that you see here on the right is an immediate placed dental implant using some CBCT images, which I was able to place myself. This is a few years ago. So why is this information relevant and important to you? Well, as many of you are experiencing already, most dental students have limited to no practical experience in restoring dental implants. If you do have any experience, it's fairly limited. A lot of this stuff is sent off to AGD or to the residents or to the senior students. So many of us in dental school don't have a lot of restorative opportunities. We know going forward that dental implants are the standard of care for restoring a single tooth edentulous space in almost every situation. And most GPs, if they do place dental implants, won't place them until years after graduation. So it's helpful to have some of this detail dialed in. Many implant placing specialists are also not focused on the restorative piece of the puzzle. So it's helpful when you begin to do this that you can coordinate some of your efforts with a specialist to give them better input from the standpoint of what you want, where you want it, et cetera, et cetera. You'll see on the right side of the screen, sorry, I should have explained this. This is kind of a little tracer of where we're going in the course. And it'll kind of click through as we go down. So in case some of you get bored, you'll be able to see how much is left. Let's talk about a couple of cases. This is a case that I inherited from another general dentist at the office I started working at in Independence, Missouri in 2007. This is a picture of a model, and you can see these implants are not necessarily lined up. They're not ideal. So quite a challenge here to restore. Fortunately, we had some magicians in the dental lab that were able to make this 5-unit cantilever bridge look really, really, really nice. Turned out really well. Sorry, I have the gums peeled off and I couldn't find the picture with the soft tissue in place. I'm going to take a step back. We're going to digress just a little bit and talk about making sure that you have the right tool for the job. As I mentioned, dental implants for almost everybody in almost every situation is the best solution, but it's not necessarily the best solution for everyone. So these are two of my daughters. This is a few years ago. You can see they have a chopstick right here and they're watching a YouTube video. My mother-in-law sent them some chopsticks, and so they're trying to figure out how to put it in their hair, right? So they can hold their hair up. So this is my daughter Campbell. Beautiful, you know, chopstick works well for her. Same thing for my daughter Ruth Ann, wonderful, chopsticks works well for her. But again, not everybody. This doesn't work well for everybody. So this is obviously me. Believe it or not, I actually have less hair than that now. So make sure that when we get to the point where we're talking about options for our patients, make sure that we don't try to cram an option down their throat that's not necessarily the best choice, the best tool for their indication. Okay, so let's talk about diagnosing. We want to know about indications for single tooth dental implant placement and restoration, options for replacement of a single tooth edentulous space. Let's talk about good, better, best, and keeping it simple. All right, so what are my options? Well, when I sit down with a patient and they've got a single tooth edentulous space, I'm going to talk to them about basically 3 choices. You know, there's a removable option, whether it's a partial denture or a full denture. Depending on their situation, you know, this could be a great option for them financially. It may not necessarily be the best choice for them, but it is one of the options that we want to make sure that we talk with them about. There are bridge options. Now, both of these options, bridges happen to be made by our in-office CEREC machine. I made both of these bridges myself. Sorry, they're a little pixelated. Some of these pictures are kind of old. There's the bridge option, and then there's the dental implant option. And we're going to talk about both of these modalities here, the screw-retained implant crown and the cemented on an abutment implant crown here in a minute. So we want to make sure we give our patients the options that they need. Oftentimes, we as practitioners will kind of pull our punches, meaning we won't necessarily give patients the best option based on what we think that they're going to be able to afford or what we think they may choose. You know, a patient may have chosen a partial denture in the past. That doesn't necessarily mean that they're going to choose a partial denture again. So because she has a lower partial doesn't mean she wants an upper partial and vice versa. So make sure that we don't do what's called a wallet biopsy. We want to make sure that we're giving them all the options, the ideal options going forward. So when surgery isn't an option, this is a great case to kind of share with you. For this patient, surgery was not an option. It was primarily because she'd recently had chemo and radiation therapy and her lower jaw was involved in that radiation. So we couldn't do any surgery. I had consulted with her oncologist and her physician, and we decided there was no way we could do any surgery, so we had to do our best to mitigate the damage from this periapical abscess here. Now, how would you deal with this situation? This is quite a challenging situation. In a perfect world, if she was not a radiation and chemo patient, we would have jumped on an extraction and an implant or 2 or 3, depending on how many teeth she wanted to put in there. But for her, it wasn't an option. We couldn't do that. So it's time to be the hero a little bit. So we opted to do our best to save the tooth and even restore it, rather than just taking the decay out, completing an endo, sealing it at the gum line, and looking at a partial denture. We opted to try to restore it back to full function. So here's what we did. I put in 6 titanium pins after the endo, and this is a Cerasmart. It's a hybrid resin ceramic restoration. Put in a crown. This is a couple of years ago. I haven't seen her since then. I'm assuming she's okay, but the follow-up x-ray would be nice to have. But this is what we did for her. I did not put a post in this tooth. Oftentimes we'll put a post and or pins, but this one we opted for pins. And here's the kit that I like to use, the Stabilite pin kit. These are fantastic. I don't know if any of you have exposure to these. And the nice thing about it is you drill a little pilot hole, then you spin the low speed up to about 20 or 30,000 RPMs, and you engage the pin in the pilot hole and it automatically separates right there. Very, very simple. A lot simpler than when I was in dental school. So in this case, for this patient, surgery was not an option. She couldn't afford the time nor the money to do 16 weeks of hyperbaric oxygen therapy to take the tooth out, put in an implant. So ultimately, I think we did her a great service. Okay, let's talk a little bit about CBCT. My office is in the process of getting a CBCT machine installed. Hopefully within the next 14 days. We've got some of the electrical and contracting work coming in on Thursday. And then hopefully next week we'll have our CBCT machine installed, so we'll be able to do all of this planning in-house. But this is a case from, I want to say 2014, 2015 that we did. This is the boyfriend of one of the benefits coordinators back in Albuquerque. He needed a tooth extracted, which was non-restorable. And so we sent him out for a CBCT image. And then we acquired that image, or he brought it into us and we uploaded it. And I got on a video call with the lab and we worked through it. Basically what we did is looked at all these different sections and slices and placed the implant ideally where we wanted it. And so in the end, the implant was placed here after the tooth was taken out. And then we designed a crown. It was not delivered at the same time, but we designed the crown at the same time that the implant was placed. So here's this situation. Let me walk you through it. Preclinical right here, non-restorable. Now, could we have tried to push our luck and restore it with a root canal and a crown and a big core buildup? Probably could have tried. Long-term prognosis wasn't very good though. So in this case, I opted to do a guided surgery. So this is a surgical guide with the implant drill in place, and you can see a different angle of the implant drill here in place. So what I did is I decoronated the tooth. I cut the crown off the tooth. These are still roots in place right here. We decoronated the tooth, drilled the pilot hole all the way to full size. Then I removed those roots, placed the implant down in between where the roots were, put on a titanium base called a Ti-base and a scan cap, and then we scanned it into the CEREC software. And you'll see some of that here in a little bit. Then we put a little bone graft material and a little bit of gel foam and a membrane over the top, put on the healing abutment because I got really fantastic primary stability. Then he came back a couple of months later and we delivered this crown. But the crown was designed at the time of the surgery. So it's pretty awesome. Pretty cool stuff. All right. So is this an appropriate site for an implant? Let's talk a little bit about specifics.
Dr. King,
yes.
we do have one quick question. Is this considered a direct placement?
Say that again.
One question is this considered a direct placement?
So I would call it an immediate placement. So it's probably the same thing. When the tooth comes out, the implant immediately goes in. Generally speaking, I've done this a lot when the extraction crypt is generally healthy and we can get good primary stability. So yeah, I think the answer is yes. That is a direct or an immediate placement. So.
And another question that says, why would you design the crown on the day of placement when the gingiva may change the healing process?
Great question. So there are a couple of different mentalities there. Basically two schools of thought. School of thought number one is we want to wait for the gingiva to heal and design the crown to accommodate the gingiva. On the other hand, if we control the gingiva, meaning if we force the gingiva to do what we want it to do, we could potentially end up with a better emergence profile, more cleansable, more aesthetic, et cetera, et cetera. So for this particular case, I opted to do a more of a lollipop shape. So the implant, comes up out of the bone, and then you got a crown that comes straight out and up. That way it yields a much more natural emergence profile coming out of the gums. Otherwise, we'd end up with the other type of a shape, and I'll show you some pictures there. But in this case, yeah, go ahead.
We have a few more questions here. Sorry to cut you off.
That's all right.
Did you do a sinus lift in this case?
So no, I did not. He ultimately didn't need it, and I think what we're seeing there is where the implant was placed. There were a couple of millimeters beyond where the implant was, where it was still solid bone. So it looks like it's into the sinus, but it's not here. Yeah, so there was no sinus lift done here.
Okay, and we have two more.
Sure.
Why did you do the pilot through the existing route?
Great question. So oftentimes I'll do a pilot through the existing root because if you can envision looking down into the root crypt, like right here, if we were to take these roots out first and then try to engage the pilot hole, the pilot drill in the center on this little point of bone, the intrafercal bone, it's difficult to get the pilot to catch, and it'll oftentimes slip in. And as we're widening that osteotomy going down to create the implant osteotomy, it's much more difficult to engage directly in the center of the bone mass. So we had picked that implant site based on where the bone mass was in between the tooth roots, if that makes any sense. So I felt like it'd be easier to go ahead and do the osteotomy through the roots and then take the roots out than doing it the other way around. Ultimately, could I have done it the other way in this case? Yes, he had tons of bone, interfercal bone. And so it would have been just fine. Did that answer the question there?
I think so, and I think the next question is very similar. Why did you decide to do the pilot hole before taking roots out instead of taking the whole tooth out first? So
yeah, it's just about stability. So I got my dental implant placement training about a year after I got out of school, and I probably placed 20 or 30 a month for the first few years until I started handing that off to my oral surgeon and periodontists. And so I placed a lot of implants. We did a lot of immediate implants, and I found that if we take the tooth root out and then drill the osteotomy, it was oftentimes difficult to get that osteotomy exactly where we wanted it. On the other hand, even though it's more work, if we drilled the osteotomy through the tooth, and you have to have really sharp instruments, and you have to make sure that you're sharpening your instruments and not reusing dull ones, then you can get that in an ideal position. Now, the key with immediate implant placement, though, is primary stability. So if there's not going to be bone there, then it's not worth trying to do. But in my opinion, if we can do it through the roots, we'll oftentimes be able to place it more ideally than if we couldn't. So.
Okay, and one more question. Mm-hmm. How did you know what the correct angulation was for the pilot hole?
So with let me see if I can go back. It may not let me go back. I'm going to hit escape here. Well, it's not letting me go back, Jessica. Basically, we had a guide, a surgical guide, and in that guide, there's a cylinder of metal with a key that drives the drill. So the drill basically goes exactly where you want it to be, and all that was set up in advance. So with the implant. With the lab, I set up exactly the placement I wanted that implant to be in. So the surgical guide was set specifically for that particular location. That way it would go to the right depth. And these are all based on some really widely available surgical guides and toolkits with keys and sleeves that you can use for every major implant system that's out there.
All right, and it's sparking a lot more questions. So cool. Does that make extracting the roots more challenging?
It sure can, and that's why it's a lot more work to do it that way. Sometimes it's a lot easier to take the tooth out and then try to do it, but then there's a trade-off. You may not be able to get the implant in the ideal site. On the other hand, sometimes it's easier to pull out the high-speed handpiece and create a little notch and engage it and then get your implant osteotomy started after that. But yes, it's usually easier to take the root out first, then place the osteotomy or you know, the pilot drill, et cetera, but sometimes it's not. But if you do have a guide, it doesn't really matter either way, because the guide will force that drill to go in exactly the same place, exactly the right place.
Well, thank you. I think that's all the questions for now.
Cool, sure. All right, so here's what I would suggest as far as spacing requirements. You know, generally it comes down to appropriate clinical conditions from the standpoint of how much bone do we have adjacent to specific locations. You know, generally between an implant and a tooth, you want a couple of millimeters, and these are general rules. You know, I think the absolute minimum is 1 millimeter. In between two implants, we want 3 millimeters. A lot of that is to preserve the papilla. You know, tooth and implant 2 millimeters. Then buccal, we want to make sure we have enough bone on the buccal and the lingual or the palatal. So this is what I would suggest. So as you're identifying implant sites to the patient, it's sure helpful to have a 3D image. But if you can't have a 3D image, you know, you can use some intraoral measuring, whether you use a caliper or whatever, to determine if you have adequate bone. If you're not going to be the one placing the implant, the surgeon, whether it's a periodontist or another general dentist or an oral surgeon, should be able to make that judgment based on what they see clinically. So having adequate bone is really the start to making sure that we have a good long-term outcome for our patients. And like I mentioned before, this is oftentimes the point where we decide an implant is either not a good option or may become cost prohibitive, meaning the patient's going to need a sinus lift and a block graft and, you know, all sorts of other heroic measures. And at that point, you know, when you go from $4,000 or $5,000 for a single tooth implant to $10,000, many times the patient will be like, yeah, that's a value judgment. I'm going to go to the bridge instead. So it's helpful to know going into it by doing some research and preclinical planning, what appropriate, you know, what measures you have in place to do that. All right. So talking to patients, once we've identified the options and talked to them about, you know, best, good, better, best, et cetera, having a very simple discussion with them about what they need and why. Many patients don't want the gory details. Some do. We've got a lot of engineers here in O'Fallon outside of St. Louis that work for Boeing, and they want all the details. I mean, they want us to tell them how much torque they're putting on that, you know, that implant abutment screw. I find, though, most patients don't. They just want to know that it's an artificial tooth root and you're going to put a tooth on it when it's healed. The real critical piece of the puzzle that I think you'll benefit from if you can incorporate this early on into your practice life is helping patients understand the consequences of their choices, and doing nothing is a choice, and the urgency with which they need to move forward. You know, many patients are like, you sit down and the doctor on that bottom line, it says avoid the you need approach. The doctor says, well, you need a crown. And that's all the information they get. Well, they don't know, okay, well, I have a large two-surface cavity that's, you know, undermining a big silver filling, and there's a fracture in the front of that tooth. If left untreated, this tooth is going to break and it's going to need a root canal if it's even safe. And here's where you could be if we don't treat it, and we ought to try to treat that as soon as possible. Otherwise, you're going to end up coming in here for whatever you may need. So helping patients to understand the consequences and the urgency, and then avoiding the you need approach is really critical. But keep it simple, especially with dental implants. So let's assume we've had the implant placed, whether we did it or somebody else did it. There's always a full stop after the implant's placed where there has to be an evaluation made of whether or not we can move forward to the next step. I had a patient yesterday, and there are a couple of pictures of her case that you'll see here, who came in last week for I think it was just a recare exam, a cleaning exam, but her implant had been placed for like 4 or 5 months. So she was ready for restoration. And so we went ahead and scanned and designed her crown, but I didn't put that crown in until she came in yesterday and had the periodontist who placed the implant give me the thumbs up. So we want to make sure this is probably for liability reason, and also to make sure that the patient is adequately healed. We want to make sure that we get that clearance from the surgeon who placed it, whether it was an oral surgeon or periodontist or another general dentist or us. Make sure there's clearance indicated clearly in the chart.
Dr. King, we do have one more question. How do you feel about cantilevering with implant-supported restorations?
So cantilevering kind of depends on the situation. Generally, as a general rule, if it's managed and the occlusion is appropriate, I think it's totally fine. I mean, if you look at an all-on-4 restoration, for instance, once we start abutting implants together, you can cantilever, you know, I want to say half the width of the inner implant distance off the back end without any issues. The question is, if you have a single dental implant, you've got a cantilever off the end, that puts you at a high risk of some sort of a failure. There are a couple other presentations that I share, and there's some real specifics in there. A lot of it has to do with the implant size and the restoration height, the implant restoration space, and then also the volume and how much distance you've got on the cantilever. So I'd be very cautious, just like with a cantilever bridge on natural teeth. The more cantilever pressure is there, cantilever force is there, the higher the risk of some untoward outcome. But yes, you can cantilever within reason, and I think it's half, if you have 2 implants, it's half the width of the inner implant distance you can cantilever. That's the generally accepted rule in my understanding.
Great, thank you.
You bet. So we've got the clearance, parts and pieces. There's a ton of different parts and pieces, and it all depends on what you're doing and what option, what restorative technique you're using. When do we order these? How do we do this? Patient education and all the financial puzzle pieces. These are important things that we need to make sure we're ready to do before we move to the next step. So this, for instance, is an example of ordering the wrong parts and pieces. So I like to do all of my implant crowns in office with our CEREC machine. We use a tie base, we scan, we design it, we manufacture them, whether it's a custom hybrid abutment or a hybrid abutment crown and it's screw retained or cemented, we try to manufacture them all in-house. So this one, I ordered the wrong piece, and I guess you'll see that in a minute. I ordered the wrong piece for that one, and I'll show you what happened. Essentially, there's a scan cap, or I'm sorry, a scan body and a tie base, and they're different heights. And so my assistant misheard me, so she ordered the scan body and not the tie base. So the crown came out really, really tall. I'll show you that in a second. This is an implant surgery that I did myself. This is just a 1-minute video. We've already prepared the osteotomies. This is an implant system from Taiwan called the TI1, T-I-O-N-E, placement of the implant there. We did not do any cantilevers on this case. They were 2 independent individual implant crowns. Many people often ask, well, what's the stability? What kind of torque do we need as we're placing the implants? I would suggest to listen to the manufacturer recommendations here. If you cross over 80 Newton centimeters of torque, chances are really good you're going to start damaging bone and then end up with a necrotic implant and you get to redo it. So be real cautious here.
Dr. King, we do have a student
Yes.
that asked, do you mean a scan post?
Scan post. Yes. Scan
Okay.
post versus tie base. Thanks for the clarification. Yep. Scan posts are taller and they're easier to get down into the deeper implant placements. Yep. All right. So here's that case. I'd forgotten I'd stuck that video in there. So this is what happens when you tell the computer you're using a scan post, but you use a tie base. You get a crown that's like 8 millimeters too tall. And I didn't realize that until I put it on the model and, you know, thought to myself, I don't think that's going to adjust into the bite. So make sure when you order the right pieces, that you're ordering pieces, when you order pieces, that you order the right pieces, especially if you have an intraoral in-office scanner and manufacturing system in place. And there are lots of parts and pieces. So many of you may be familiar with this ELOS system. This is a Nobel Biocare product. Basically, you put the little scan bodies onto scan post onto the implant, and you scan it. You can send it off through CEREC Connect or your E4D or your your intraoral scanner, whatever it is, and they'll design and manufacture and send back a crown or an abutment. And usually, you can get it back in office in 3 or 4 days. It's really pretty fast. So lots of different options. These are titanium bases, tie bases. This is the process that we use to affix the tie base to the abutment and then to the crown in the mouth. So here we've got a screw retained crown that's going to attach to the tie base. Here we've got a cement retained crown that's going to attach to the custom abutment that's going to attach to the tie base. Excuse me. And then the same thing here. Nobel Biocare, this is their internal conical connection impression coping set, the larger, the medium, the small, and then the 3.0. And then of course, all sorts of different tools depending on what you're doing. So make sure as you're getting into implant restorations that you have the right tools. And 3 or 4 slides ago, we talked about ordering the right tools or ordering the right parts. I would order the parts if you've got an established relationship with a patient, you're not worried about them coming back. I would order the parts when the implant's placed so that you can have it, because time moves really, really quickly in a busy office. And suddenly you look back and you realize, oh, that was 5 months ago we placed that implant and I don't have the part. So I'd order it, put their name on it. We like to put it in a Ziploc baggie and tape it to the inside of a door in the lab so we know where it is. Okay, so second stage surgery. So this is assuming we've got all the clearance, we've got the surgical clearance, so you're good to go and restore. These are 3 implants that I placed long ago in a galaxy far away. So if you are doing the second stage surgery, it's really pretty straightforward. If the implant is not visible, you want to locate the implant, obviously. And I like to use a perio probe. I'll numb the patient, usually just the gingiva. Numb the patient, and then I'll kind of poke around a little bit until I find that implant. And oftentimes you can see it if it doesn't have a healing abutment, or if it does. Tissue punch versus surgical flap. I usually like to use a punch. I don't normally, unless I'm worried there's going to be bone exposed over the top. I normally use a punch. I don't like to lay a full thickness flap. In some situations, it's a better option though. Now, the question is, are we going to need to remove bone? Sometimes you will, especially if you've put in just the cover screw and not a healing abutment. If the bone is low, or the implant is low in the bone, which is great for clinical restorability, then you may have a little bone that's grown up over the top. So you have to very cautiously remove that bone. If it's a very thin layer, you can flick it off with a curette, a surgical curette, or you can use a low-speed handpiece with a sharp round burr, like a size 8 round burr. But titanium is very soft, so if you start digging into that implant, you're going to damage the implant, so you have to be very, very cautious. I would caution you against using a high-speed handpiece next to a dental implant. So a couple of pictures here.
Going back one slide, one of our students asked, which technique do you prefer? Do you prefer more open or, closed or open tray impression technique?
Oh, we will get there. We'll get there in just a minute. So open and closed tray, we'll talk about that in depth here in a little bit. So second stage surgery. This is a case, actually, I saw this patient earlier today and I told her you're going to be the source of, some discussion is going to be made of your implant situation here. And she was pretty excited. So she says hi. Lisa is her name. Anyway, this is an implant, an Astra implant that was placed by a specialist, really, really deep in the bone. You can see there's like 6 millimeters over the top of that. And when she came in, they could not get an impression post in there because the bone had grown over, which was great. So I actually had to anesthetize her a little bit. I didn't expose the bone or make a full thickness flap. I just used, you did use a high speed, but I used a big 856-025 fine diamond and just kind of widened that opening just a little bit until we could get that impression coping on there. Then we designed this ourselves. This is a titanium base. And this is a zirconia abutment, and then an EMAX, a lithium disilicate crown. So, all right, so let's talk a little bit about impression options. We have a couple of choices, digital and analog, and you can see implant make and platform size matter, just like that Amazon truck trying to squeeze through there. Size is important. We have to make sure we have the right size. Watch that one more time here because it's kind of funny. Fortunately, McDonald's has foreseen this problem, and maybe they're measuring Amazon trucks and have a breakaway arm there. So let's talk about understanding the options available when restoring single-tooth dental implants. So here we have closed tray and open tray impressions. We'll talk a little bit about the specifics of those and the benefits, the pros and cons. Closed tray is obviously a tray that doesn't have an opening made for the implant impression analog, and open tray is where we'll cut a little window so that we can leave the impression coping in the impression, manage these screws, unscrew them, and pull the copings out when the impression comes out of the mouth. So let's talk a little bit about those specifics. This is a laboratory analog, and this is a closed tray impression coping for a Nobel internal conical regular platform implant. Open tray impression process. Let's talk about this a little bit. So placing the fixture, you always want to verify the seat of the fixture, the impression coping, with an x-ray. And I usually tell my assistants, take a bite wing x-ray, because I want that angulation, but I want the bite wing x-ray more like a PA. Now they should be taking them that way anyway. The PAs should be in the right angulation, but sometimes you get that angulation against the palate or the lingual portion of the jaw. So verify the seat with an x-ray, trying the x-ray with the cutouts, and then usually a two-stage impression, a little bit of light-bodied or a more runny impression material around the analogs, and then a heavier material in the tray. Once you remove them, once you put the impression material in there and it sets, then you'll unscrew these, and then the whole impression tray comes out with the copings in place. So this is where we have to be very, very cautious if you have multiple implants and they're undercut to each other. If the impression copings are engaged inside the implant, you may not be able to get that impression out of the patient's mouth. So it's helpful at this point, and we won't talk about this now, it's helpful to consider a multi-unit abutment in that case if you have multiple implants. And those multi-unit abutments actually take the angulation of the implant and they can change it. So if you've got a really distal leaning implant, they can actually alter that with the multi-unit angled abutment so it's more straight up and down. So be cautious at this step if you have multiple implants. If they're undercut to each other, you won't be able to pull them straight out with the impression. You could damage the patient or potentially hurt the the implant interface. Always inspect your impressions. Always inspect them. You want to make sure they're perfect. If they're not perfect, take it again. You're better off taking it while the patient's in the office than you are calling the patient back in a week and saying, hey, the lab would like new impressions. Can you come back, take another day or a half day off of work and put your kids in babysitting so I can take another impression? Because there was a big bubble and I probably should have seen that. So inspect your impressions. All right, closed tray impressions. Placement of the impression fixture, you always want to verify, like I said before, with an x-ray. And then we're going to do the two-stage impressions, which is what I'd recommend. Remove the impression tray after it sets. Verify that everything looks good. These, closed tray impression copings will snap back into the impression, but they do come in different widths. Like I could get yellow and really narrow, really short, really tall. So make sure that you're putting them in the correct location. And I've got a case here I'll show you in a little bit where we use the same implant platform size, but different widths of impression copings. So inspect those impressions. And so here's that case. So this is I don't remember the exact width, but this is a regular platform impression coping here. And there was the same regular platform, but a narrower impression coping there. So this was a great kind of an example of two different sizes of the same implant platform. But inspect those impressions, depending on what you got going on, you want to make sure you have adequate detail before moving on to the next step, especially so we don't waste our time and the patient's time. So what does the lab need? Well, they obviously need the impressions or the models if you're going to pour them up. Restoration arch, the opposing arch, the bite impression, the restoration shade. Depending on how much detail you want to give them, you can give them as much detail as you want. And I would suggest for your first few cases, you want to make sure that you actually call the lab and talk to their specialist and see what information they want before you send them a case. Because a lot of times they'll be like, yeah, I need a lot more information than this. Sometimes they won't. But communicate more. Communicating more is much better than communicating less. Digital impressions, obviously it's kind of the same process as the analog impressions. We're going to take off the healing abutment. We're going to place a scanning fixture. We're going to confirm that it's seated with an x-ray like all the other impression copings. Complete the scanning, appropriate scanning, and then replace the healing abutment. So, quick break from implants. Let's talk about digital dentistry. Many of you are very familiar with some of the things that digital dentistry can do. All of these cases that you see here are cases that I've had an opportunity to do in a single appointment in the dental office with CEREC. So mostly smile makeover stuff is what you're seeing here. For me, looking at all these, this one probably on the lower right is one of my favorites because he came in, this was his appearance here, and he wanted a new smile. He had already been quoted from Clear Choice $29,000 plus surgery for an all-on-4. And what we did was 6 Vita crowns. That's a feldspathic porcelain. And because he had an HMO insurance plan, it was not a really high dollar treatment fee. But in the end, he got a high dollar smile. So you can see the preparations there. And this was about 4 hours worth of work. So he went from this to this in 4 hours, and it was a mind-blowing transformation. So definitely get into the digital dentistry stuff, okay? All right, moving on. So I'm gonna show you just a couple of videos of the actual scanning process using CEREC. So you can see me removing the healing abutment there. And this is one of my dental assistants in Albuquerque. We're going to take a look at the implant that's in place. And this implant was placed by one of my partners out there, Dr. Mark Urbane. Call him out. He's a great man. Had a lot of fun working with him. So that's the titanium base. And that's the piece I got accidentally switched with a scan post. That's the titanium base that we're going to screw into place. Once it's screwed into place, I'm going to put on a scan cap, which is a little plastic cap that basically helps the computer to see a little bit better. So here comes the scan cap. We'll get that in place. The scan cap has to be oriented exactly right. There's a little groove and a notch that have to mesh together. Otherwise, you won't be able to get a good scan. It'll actually think the implant's going in a different direction. So once the scan cap's in place, then we do the scanning. And here's the scanning. And for whatever reason, this image is a lot clearer. So that's a CEREC OmniCam. That's the same version of the camera that I use today. And we're just scanning, creating a 3D model.
Dr. King, we do have one question.
Uh-huh.
How long do you keep the healing abutment after uncovering the implant?
How long do I keep it?
Keep the healing abutment after uncovering the implant.
So if we're done with the healing abutment, like done, I'll throw them away. We don't reuse them. We don't sterilize them anymore. We used to. But yeah, we throw them away now. The general protocol now is to throw those away. I know Nobel, I think, will give them to you for free if you buy their implants. Yeah, usually we try to leave it off as little as possible. So if we're going to be using, like if we're going to scan his case and then send him back home and then design it and have him come back in a couple of weeks, we'll put that healing abutment right back on though. So we'll reuse it for the same patient, but not in between patients. Okay, and the question is how long between stage 1 and stage 2? Oh, what's the healing interval? Okay, so, so we're talking about the uncovering and then the restoration appointment. So for me, I'll do it at the same time. I mean, it can be 0 time. So like if I've got an implant that's ready for restoration, if I do a tissue punch, and then I'll go ahead and immediately restore it, I'll scan it and then put the healing abutment on there. Or we can actually design the final restoration at the same appointment. So they'll go from having a tissue completely over the implant, not even visible, to having a crown at the same time. If we manage the pressure and the emergence profile and design of the emergence profile, then I personally don't see any need to wait, unless you're doing some tissue sculpting. So if you're going to manage the tissue like anterior aesthetics, then usually we'll do it in 2-week intervals. So we'll put on a healing abutment, we'll add some composite to it, we'll have it back in a couple of weeks and see if we like the tissue. If it's good, then we'll go and proceed. If not, we'll do some more contouring, adjust the tissue, whether it's with a high speed or with more composite, shaping that tissue and have them back in a couple of weeks. Hopefully that answers. And one more, what are your thoughts of directly loading an implant right after placement? So I've done that a lot. And none of the implants I've directly loaded have failed. But it comes down to a couple of really key things in my mind. Managing the occlusion really, really cautiously, managing patient expectations, and then making sure you have good initial stability. In every situation, and I've probably done it, I don't know, a couple dozen times, it went just fine. A couple of times we actually redid the crowns because after things healed, we felt like the crown contour could be a little bit better, and I redid those at my cost. But generally, if things are managed well, we'll do that. Since I'm sending all my implant placements to the oral surgeon, the periodontist, they don't normally like us to do that. So usually my periodontist is having us wait in a virgin site where everything's healed anywhere from 2 to 4 months, depending on the initial primary stability. The oral surgeon is about the same. But if we've got an extraction and an immediate placement and the bone graft, they'll wait 6 months. You're better off giving it a couple of months rather than trying to force it and then going backwards. But yeah, I've done it in the past myself and had good success, but I haven't done it in a while. So. Good? Thank you. You're welcome. Okay, so you can see just finishing the scanning process here. We are running out of time here. We're gonna have to hop through these slides pretty quickly. So scanning the upper, scanning the lower, scanning the bite. You have to be cautious though at this stage that when they bite down, they don't hit that the scan body, otherwise they could deform it and even damage the implant or the tie base. Then we're gonna take it off. We're gonna put on the healing abutment. And then the next portion of the video that you see is just some of the design process here. And this is an older version of the software, not the same case. But basically the design process where we can design the implant restoration on the implant in the same appointment. So if we were to manufacture an Emax hybrid abutment crown, it would take the manufacturing machine, the milling machine, sorry, it would take it about 25 minutes to cut the block out of the crown, or the crown out of the block. And then we'd have to put it in the furnace for about another 25 minutes. So it's at least an hour wait if we do it that way.
And have you ever had any discrepancy between analog and digital impressions?
I've never really, now between fit and delivery, I have, and I can trace all those discrepancies, all of them, back to the impression piece, whether it's a digital piece or an analog piece, not being seated correctly. So that's why it's so important that we make sure that we verify the seat correctly with an x-ray, and also make sure you have the right size of pieces. You know, with that Astra implant I was telling you, there are a couple of different sizes. There's the Astra and then there's the Astra EV, and both of the regular platform sizes are a gold color impression post. So it's fortunate they made the screw threading a different size, otherwise people would be using, you know, the wrong impression post. So yes, I have, but it all comes down to not having delivered or taken the impression correctly. All right, now we get into the nitty gritty. Restoration types. So we basically have two types. We're talking about single dental implant restorations. We have the cement retained and the screw retained. For our intents and purposes here, we're going to ignore the connection between the titanium and whatever's on top of it. We're focusing on the abutment piece and the crown over the top of it. Okay? So we're going to talk about these workflows for successful single tooth dental implant restorations. For cement retained, there are some benefits there. There's no access hole. There's no need to patch. Conventional cementation, though, process is a marginally higher risk for peri-implantitis due to cement necrosis. You can see this spot right here on the patient's upper left behind number 14. So these are also all Emax, lithium disilicate. This was actually an x-ray that we took today on this lady. She was also in this morning. So we were able to recover that piece. This is a Verilink aesthetic, but these implants were in great shape. These are some of the parts and pieces. Here's the tie base. Here's an abutment. This is a zirconia abutment that was, again, manufactured in office, and that's an Emax crown for a different case. So there are some benefits to cement retained, namely cosmetics, and usually in the anterior we do cement retained for cosmetics because we can't put an access hole right through the incised ledge, but there are drawbacks. Here is the cement retained, some more pictures of that same case. This is intentionally misaligned, I'm assuming. Screw retained. Posterior crowns almost always will come this way, generally, because they're a little easier to manage. And there's no cement, there's less risk of cement necrosis. They're easier to retrieve and better retention. And oftentimes, we can actually order a zirconia restoration where the piece that mates with the implant is also zirconia. However, they'll usually have a little titanium ring that sits on the top of the implant. So screw retained versus cement retained, here's a couple of pictures there. These can be very cosmetic, very aesthetic. The only drawback is we have to put a little patch of composite resin over the Teflon tape that covers the screw hole. So usually those will acquire a little bit of stain over time. But we generally like to do these in the posterior because they're easier to manage and it's technically a stronger restoration. All right, delivery process. So number one, if the patient still has a healing abutment, remove the healing abutment. Now, occasionally we'll have patients that have healing abutments that get lost for whatever reason. Sometimes, even though we've tightened them, the healing abutment will come off. And I've had several patients call me up, hey, my implant fell out. Oh my gosh, I'll meet you at the office. And they show up and they've got the little healing abutment. Oh, okay, well, let's screw that back in, no problem. If you feel like you can still restore the implant at that appointment, great. If not, we may need to do a little more tissue forming. So numb the patient up, remove the excess tissue, put the healing abutment back on, wait a couple of weeks. So remove the healing abutment, try in the abutment restoration, verify the tooth and tissue pressure. And this is one of the interesting things about implants. It's different, implant crowns, I should say. It's different from regular crowns because with a regular crown, there's almost never pressure from the gingiva on the crown that's going to keep it from being seated. But as you can see here, when you have the lollipop shape, which is what I mentioned before, oftentimes there's pressure directly underneath where the implant crown is hitting the gums. And so that may prevent the crown from seating. So we have to be cautious of that. And oftentimes we'll adjust our contacts because we assume it's the contact. And then we realize, oh no, it's actually the pressure from the gingiva. And we finally get it seated and the contacts are wide open and we have to remanufacture the crown. So be cautious there. Verify the tissue seating. Yeah.
We do have a few questions here.
Sure.
When placing mandibular implants, what are your thoughts on some patients having larger size peripheral nerves from the IAN that may cause potential paresthesis issue down the road? Also, does CBCT show all potential peripheral nerves and that may pronate or protonate nerve complications?
Sure. So CBCT will give us a really, really clear picture of all those nerves, accessory nerves, and, you know, especially the IA nerves. I've never had a patient, you know, I've probably placed personally more than 1,000 implants and restored probably about the same on top of that. And I've never had a patient with permanent paresthesia. I've had some patients with transient paresthesia, and one in particular was a patient, I want to say it was tooth number 18 that I'd taken out and put in a big fat, it was the same day extraction and implant placement. I put in a big fat Zimmer implant. And she called me that night on the emergency number and she was having tingling and numbness all the way up to her lip and chin. And so I met her at the office and all I had to do was reverse that implant about a quarter of a turn and it immediately resolved. Even though we weren't close to the nerve, I think what had happened was, because I could verify space on the x-ray, you know, it was a 2D, it was a panoramic, of course, but I think the implant placement had created pressure on the bone, which had caused some sort of pressure on those nerves. So I know there's a risk out there, and I think if we broadcast that risk and we deal with the fallout of potential complications appropriately and quickly, I think the risk of having any big issues is pretty slim.
Okay. And screw retained or stronger than cement retained?
Generally, yes. And the primary reason for that is there's a junction between the cement and another restoration, whereas with screw retained, you've got a block. It's a unified material. However, you know, with today's cementation processes, it may not be that much greater. And I don't know what the testing out there specifically says, but generally the screw retained are much stronger. So.
Okay, and our last question, why did you use a cantilever in this case?
So that was actually when I was restoring that I didn't place. And she had an implant, an immediate implant placed by another doctor. I don't know what model of implant that is. And she had the opposite style of crown. So basically that implant came up out of the gums and then the abutment came up and then went back down to kind of follow the contour of the gingiva and then back up to the occlusal table. So we opted to go ahead and restore, but the whole cantilever is under the gum tissue. So in this situation, I was comfortable with the cantilever because I managed the occlusion. The mesial portion of that tooth didn't have any active occlusion on it, even in excursive or protrusive patterns. So.
Great, and we have two more. What do you use to cement the implant crowns?
So if we're cementing a crown to an abutment, which you don't see any of those here, and I'll explain that in just a second. If we're cementing a crown to an abutment, what I like to use is any conventional cement. I mean, any cement that I would normally use for a crown. I don't use temporary cement. I know a lot of us were taught to use temporary cement to cement a crown because you've got such high tolerances between the abutment and the crown. I don't do that. I've had, I don't know, half a dozen or so, not a ton, but I've had a lot of patients come back who have had that temporary cement fail and then we need to re-cement it again. It's just fine, in my opinion, to use conventional cement. If I ever were to need to recover that, I could always open an access hole and unscrew the whole thing in one. But I use regular cement, whatever you normally use, which for me is very Link aesthetic. So.
All right. And in your experience, have the porcelain crowns been able to withstand occlusal forces and not crack, or are PFM implant crowns stronger?
So it depends on how you're testing it. So in my experience, the crowns that you're seeing here, these are all lithium disilicate, EMAX. And with the thickness that we have here, even this narrow thickness on the one side, I personally am not concerned. Now, have I had some fail? Sure. But I've also probably had an equal number of PFM crowns, whether they're implant crowns or otherwise, that have lost some of the porcelain. So I think if it's managed appropriately, I think just about any material, given it's appropriate in this indication, can work well. So for instance, I started using CEREC in 2006, 2007, and the only material for crowns that I had access to is a feldspathic ceramic, Vita Mark II, and the corresponding Sirona ceramic, which is roughly equivalent to the shear strength of enamel to dentin, so about 160 megapascals. This material, EMAX, rivals 5 times that strength. They're averaging 500 megapascals under a 1 millimeter flex stress test, but they normally average up to 750 megapascals. Now, on top of that, if we're talking about zirconia, and the one I showed you before that we manufactured in office, those zirconias are 16 to 1800 megapascals. So I think the material is plenty strong. In some indications, though, depending on the thickness that you have, a metal restoration, whether it's a titanium abutment, a full titanium abutment, or a PFM bridge or implant restoration may be better. It just depends on the situation. But personally, I'm comfortable using these ceramics, again, given following appropriate recommendations and in the right indication for just about everything, because that's what we do all day anyway.
Great. And how did you manage to place screw retained on tooth number 20, with that severe angulation?
Talking about these guys over here. So the nice thing about it, when these go together, it's a conical connection. So it's not a straight, it's not a straight, I don't know how to say that. The draw path allows for some play. So and that's a little overlap, so it's not a perfectly straight x-ray, kind of like you'd see bite wings overlapped. So I think what I ended up doing is I think I put on number 20 first, and then 21 first, and then 20, and then 19. I don't remember the order, but they all went in at the same time without too much difficulty, because as you put them in there, there's still a little bit of play until they seat all the way down into the implant. If they were perfectly cylindrical, though, those interfaces have a little bit of taper. So it allows for some play as you're seating them. Yeah, that was a tough case. I remember that being a tough case. Her name is Ingrid, incidentally. I remember her. She's from Germany. Sweet lady from Albuquerque.
And one more question. Yeah. What certification do you need to become implant certified, and how long does it take to get that certification?
So I know there are a bunch of fellowships that you can do. I personally never went through any of those. My implant training consisted of training through the Dr. Dick Barnes group, and my trainer was John Julian, who does a lot of training. I'm not sure if he's still training now, but I basically spent three days of intensive implant training on site in an office with him, and I think there was a handful of other doctors there. We spent the time there. We had done a bunch of research beforehand. I think I paid a few $1,000s for the CE course. And then for my first few cases, I had the rep from Ankylos, Don Lujan, who's out of Kansas City, great man if you need a referral for a great guy. I had him with me in the surgery on my first few cases to kind of walk me through it. But personally, I don't have any special certification. I know there's some great courses out there. You can go through a fellowship and some academies that do a great job. Ultimately, as a general dentist, I'm held to the same standards of care as a surgeon would be. So I have to be cautious and know my limitations and not bite off more than I can chew. But ultimately, if it's within my license and I've got appropriate training and am held to the same standard of care and execute those standards of care, I'm comfortable doing almost every implant. So, but again, I don't do a lot anymore. More advanced training, And I think my time is better off spent cutting crowns and doing bridges and everything like that. So.
Great, thank you.
You bet. Okay, so let's finish the delivery process real quick. I know we're running out of time here. We're almost there. Just a few more slides. So delivery process, removing the healing abutment, trying to the abutment restoration. Watch the tissue pressure. That's really, really critical. Adjust the seat, then verify the seat with an x-ray. So hand tighten down to seat, then verify that seat with an x-ray. Then you want to torque. What I like to do is I use a double torque test. So essentially I'm going to torque the screw to the appropriate torque, and then let the implant and the abutment sit for at least 5 minutes. And then I'll check it again. And almost always I'll get that screw to settle in a little bit more, because we've got dissimilar metals that are meshing together, a stainless steel screw and a titanium abutment. And so they're gonna settle, titanium abutment and titanium implant. They're gonna settle a little bit. So running around the office that'll last till the end of time. Okay, so here's the question: to bond, cement, or loop? That is the question for any of you Hamlet nerds out there. Manage the occlusion. This is really, 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 really critical. We got to manage the occlusion for a single tooth implant restoration. The only contact should be in maximum intercuspation position. That's the only contact. You don't want any excursive or protrusive or retrusive interferences, so you have to watch those canines. We want to make sure that nothing is going to catch, because it's those lateral forces that are going to cause the damage. And gradually they're going to work their way to creating some stress, because titanium will flex. They'll create some stress at the neck of the implant, which can potentially cause bone loss. So manage that occlusion. You're in charge of it, manage it. Post-op, for me, post-operatively, I like to see my patients in a couple of weeks just to make sure that their occlusion's good and check their tissue. On occasion, we see a patient who has a big inflammatory process happening around the implant. It's really easy to treat, but the longer you let it go, the worse off it gets. So normally what we do, make a small incision, expose that area, irrigate with chlorhexidine, remove any necrotic tissue if there is any, and put a suture in there and have her back in a couple of weeks. Her or him, I should say. Usually we take a bite wing and a PA at 6 months, just to make sure everything is healed. And that's about it. So from the standpoint of what we've talked about today, we provided methods and processes to diagnose and educate patients on single tooth dental implant therapy, mostly keeping it simple, explaining those consequences and the urgency. We've talked about the options that we have when restoring single tooth dental implants, and some workflows for doing that digitally and analogically, if that's a word. So what other questions are there? What questions does anybody have?
Yes, we're going to give them a second to type. Here's one. If you're replacing a canine with an implant and PT had previously canine guidance, how do you deal with that? So
I'd probably transition him to group function on that side. And I think it's mostly about making sure that we're managing the guidance so that we don't compromise the long-term outcome of the implant. My worry would be with an implant in particular, on a canine, the lateral forces, like I mentioned, will cause over time a flex, and you'll either get a loosened implant screw, which we can deal with pretty easily, or you'll get a fractured abutment or crown or loss of the implant. So it's worthwhile considering transitioning them to a group function on that side.
All right, and next question. In a single restoration in MIP, shouldn't be any contacts in working and non-working?
Right, yeah, so basically a single implant restoration, what I'd suggest is the only contact they should have is a maximum clench, when they maximum clench. So all the other teeth are gonna meet first, then the implant will come together last in maximum clench. And then when you guide, when you slide, working, non-working, protrusive, retrusive, all these movements, there should be no drag marks on that articulating paper. Otherwise, like I said, you risk some sort of flexing over time and fracturing the implant, either the abutment or screw loosening. Incidentally, there are a bunch of studies out there that talk about how the implant itself won't fail necessarily, or the abutment won't fail usually. It's the screw that'll loosen and fail, because that's the weakest link, unless you've designed your implant restoration too thin or it's manufactured too thin. So yeah, we have to be real cautious to control all those factors. And when you have implants that are butted together, then the whole playing field changes. And we can manage those excursive and protrusive interferences with a little more control on the implants because they're connected in more than one plane.
And what traditional final impression material do you use typically? PVS or polyether?
PVS, yep, or VPS, depending on if you're a purist or not. Yeah, so I don't normally use polyether. I don't think I've used that in a long time, although I've heard good things about it. I usually use PVS if we're gonna use it, but most of the time we're scanning.
And what do you tell the patient when educating regarding home care?
So we demonstrate it, and it takes a little bit of new training. You know, most implant crowns, when you floss, you're gonna floss down and then under the crown, gently down under the gums. You're not gonna create bleeding intentionally, but sometimes they will bleed a little bit, and if they do, we wanna know. But conventional brushing and flossing with specific attention to doing some flossing that goes underneath the emergence profile of that implant. It's often that we see patients come back and they have plaque hiding in between the implant and the gingiva because they're not taking that floss far enough. And that's a problem with almost all patients anyway.
Great. And is there any specific reason for using an Emax in posteriors instead of a zirconia?
Yes. So as a general rule, my preference is to use Emax over zirconia unless Emax fails more than once. And the rationale for that is mostly, well, it's two things. Number one, bondability. Number two, aesthetics. Even though we have some super translucent multi-layer zirconias like the katana blocks, which we have some of, bondability-wise and control and aesthetics, being that I don't do a whole lot of infiltration zirconia staining techniques, I feel much better off using Emax because it's tried and true. It's been out there. There's some more materials that are coming out, but generally I'm comfortable with Emax. I have Emax in my mouth. I trust the material itself, and it's a good material. Now, is zirconia stronger? Absolutely. Certain zirconias are much stronger than Emax, but we can't necessarily default to always using zirconia when there are other benefits elsewhere. And I like to use this example for my patients. I mean my assistants, when they'll ask, well, why did you pick the Emax over the zirconia? And it's usually the newer assistants to the office that have worked somewhere else that, well, my doc always used zirconia everywhere. And so, I'll ask him, well, are you better off? I have a little Honda truck. I can drive my Honda truck to work and it gets me there just fine. It's got plenty of power, plenty of strength. It handles all my daily needs, right? Now I could also drive a tank to work. Yeah, it's stronger. Yeah, it's bigger. Yeah, it's better. But do I really need to? If it works for me, it works for me. I had one. It was actually an Ivoclar. I went to an Ivoclar training in Buffalo, New York. And one of the scientists mentioned to us, there were, 20 dentists. We were going through their training about Emax and staining and glazing. And he made a comment that zirconia was the answer to the question that nobody had. Now, I don't completely agree with him. I think zirconia definitely has its place, but zirconia isn't necessarily the answer to every question as it pertains to restorability. So, sorry, that was a really long answer.
That's okay. Usually, what is the optimal time to load the implant, or it varies from zones and quality of bone?
So I think a lot of it depends on, yes, the quality of bone and then the initial primary stability. I tell this to patients all the time, they'll ask me, well, are my teeth softer? I seem to get a lot of cavities. And I get to answer them and say, well, your teeth are probably softer. Let's drill a hole in one and see. And I say that jokingly. But having, cut 10,000 crowns or however many there are, you get to tell a difference between some people's teeth are very strong and some are very soft. So the same applies to bone. As a general rule, 2 to 4 months. Usually we're erring on the side of 4 months because honestly, what's a couple more months of waiting to ensure a good long-term outcome versus gaining 2 months of having a restoration there only to have it potentially fail. So usually we're 2 to 4 months. For sinus lifts, if the implant is placed at the time of the sinus lift, we usually wait 6 months because there's a lot more bone remodeling that has to happen. But usually 2 to 4 months, but to kind of re-answer your question, it depends on the situation.
Great. And what are your thoughts on hybrid implants compared to conventional 2-implant or 4-implant overdentures? In other words, are more implants always better for retention and resistance?
So I think there is a line that you have to draw somewhere. Like having 12 implants in one arch, I think that's a little overboard. I think in some situations, if we're doing a fixed prosthetic, having 6 implants could be significantly better than having 4 implants. But is it always better? I don't think so. I mean, how many thousands of cases of all-on-4s have been done that have worked really, really well with no issues? On the other hand, do we have any definitive data that supports doing 6 versus 4? I don't know. I've done a lot of the snap-on 2 implants down in the front, and they generally turn out really, really well. As long as, again, the occlusion's managed, you're following protocols, et cetera, I think generally more is better, but to a degree, you get to a point where there's diminishing returns as you add more implants. I think for any type of a fixed prosthetic, 4 implants is kind of the entry level. Usually 6 is kind of the sweet spot where most surgeons and periodontists will feel the most comfortable. I don't know that adding any more than that is better. Now, if we're talking about a removable prosthetic, of course 2 is usually the rule, but that's, I think a lot of the reason is that force is kind of obviated, it's kind of alleviated by the snap-in, the locator style or the ball style, because it allows it to move, and so there's not constant force on those implants. So yeah, more isn't always better, but sometimes it is.
All right, and one last question. When you're doing a full arch implants, don't you want to over-engineer in case a couple implants do fail?
You bet. Yeah, you definitely want to over-engineer. And so, like I said, 6 is probably going to be better than 4, but going beyond 6 isn't always necessarily better. On the lower arch, though, it seems like we have a much lower incidence of implant failure with 4 implants, just because of the nature of the bone, the quality of the bone. So in the end, a lot of it, I know it's kind of a cop-out, a lot of it is based on the clinical situation and then what you find when you get there. If you're the surgeon placing the implant, you're putting that pilot drill in there for the first time you're touching the bone, and it's rock solid, as dense as, stone, then you're probably good with just 4. On the other hand, if you come up with some type 2 bone, type 3 bone, then you may want to consider more implants to hedge your bets. Yeah, absolutely. The way we charge our fees out for all-on-4s is there's a blanket fee for an all-on-4. Now, if they have oral surgery on top of that, the sedation fee, the removal of the teeth, the alveoloplasty, that's a separate fee, but there's the all-on-4 fee, and that includes 4 or 6 or 8 implants. Honestly, once the implants are going in, it's not that much more work to place 2 more than just 4. So yeah.
Great. Well, thank you so much, Dr. King, for your time tonight. I think that's all the questions. It seems like you did a wonderful presentation. They had a lot of questions, and that's great. So,
can I just make a couple of comments before we wrap up?
Absolutely.
I sure appreciate you taking the time. Hopefully you were able to get some information here. I hope it's been worthwhile. I've been practicing since 2006, came out of dental school. And like I said, I started out in music, then business, then dentistry. And so I've got some unique experience that some don't, but that doesn't make me, the answer to everything. Certainly, if you have any questions, you can see my information down there. That's my cell phone number. That's my email address. I respond to both equally. Feel free to text, email, call. I've got a lot going on in my life, so it may take a while to get back to you, but feel free to connect with me. One of the philosophies that Pacific Dental Services espouses that really drew me to it is the perfect patient experience. Ultimately, everything we do is about our patients. If we get too focused on ourselves, on the doctors, on the processes, on the income, et cetera, then nothing really works well. Whereas if we focus on our patients and them having a positive experience, then things tend to work really, really, really well long-term. So that's all I've got for you. Again, thanks for your time. Jessica?
Yes, thank you everyone for attending. If you have any questions, you can always reach out to me, and I can get you in touch with Dr. King. I can get you in touch with our regional team. We'd love for you guys to come out and shadow in some of our offices. So if that's anything that you'd like to do, feel free to reach out to me, and I'll definitely get you in touch with our regional managers and our regional partners, and get you into our offices and kind of see what it's about. So thank you very much for attending, and feel free to reach out with any questions in the future.
Thank you. Well, Jessica, you need anything else from me?